Good morning, good afternoon, good evening, and welcome to our IASP PRF webinar. I'm Greg Carbonetti, IASP's Associate Director of Publications, and today we're excited to bring you the IASP Complex Regional Pain Syndrome Special Interest Group's Early Career Research Showcase. Today, we're going to be hearing presentations from Dr. Imana Kalishka from the University of Bristol in the UK, Caitlin Naylor, a PhD researcher at the University of Bath in the UK, Dr. Colleen Johnston-Devon from Central Queensland University in Australia, and Dr. Marc-Henri Louis from UC Louvain in Belgium. Additionally, we're excited to include up to 3 additional researchers to share their expertise with us during the Q&A session near the conclusion of today's webinar. We're absolutely going to be joined by Dr. Heike Rittner from the University of Würzburg in Germany, and we're hopeful that we'll also be joined by Dr. Ji-Yoon Moon from Seoul National University of Medicine in South Korea, and Dr. Andreas Gabel from the University of Liverpool in the UK. IASP, PRF, and the Complex Regional Pain Syndrome SIG are thankful for everyone who could join us today and remind you that today's webinar is being recorded and it will be available for later viewing at IASP's Pain Education Resource Center. I'd also encourage our viewers to utilize Zoom's Q&A feature to ask any questions you may have during today's proceedings. Furthermore, consider registering to attend the Complex Regional Pain Syndrome SIG satellite meeting, which is going to be taking place at the University of Bath in the UK just before the IASP 2024 World Congress on Pain. I'm going to be sure to distribute some information regarding that satellite meeting during today's talks. At this time, I'd like to introduce our moderators for today's webinar, Dr. Janet Bultitude and Michael Ferraro. Janet is a senior lecturer and the director of postgraduate research in the Department of Psychology at the University of Bath in the UK. She studies cognitive and sensory changes in people with chronic pain and novel interventions for these changes. She's particularly interested in coaching people around setting priorities, making difficult decisions, and navigating difficult relationships and conversations. Michael Ferraro is a doctoral researcher at Neuroscience Research Australia, whose work is centered on the evaluation of treatments for chronic pain. His research interests include clinical trials, evidence synthesis, and methodological work to improve research transparency. He's very involved at IASP and currently serves as the treasurer of IASP's MESI SIG, as well as having a prominent role in the Complex Regional Pain Syndrome SIG. With that, I'd like to pass today's proceedings over to Janet and Michael, and I'm really looking forward to hearing from all our presenters today. Thank you, guys.
Thank you. So my job is to simply welcome you on behalf of the CRPS SIG. I am one of the co-chairs of the CRPS SIG. And really, I want to just acknowledge the amount of effort and energy that's gone into organising this and thank Michael as our early career representative for thinking of this project, finding the speakers and organising it. And that's all from me. And I hand over to Michael so he can introduce the speakers.
Thank you, Janet, and thanks for the introduction as well, Greg. I just want to give a really warm welcome to everyone joining us today. So on behalf of the CRPS Special Interest Group, I'm really pleased to present our Early Career Research Showcase. So I'm a PhD student from Neuroscience Research Australia in Sydney and the Early Career Research Representative for the CRPS SIG. And I'm based in Sydney, Australia, which is located on the lands of the Gadigal people of the Eora Nation. And I'd just like to acknowledge the traditional custodians of the land on which I host this meeting and pay my respects to elders past and present. So the aim of today's webinar is to showcase the really exciting research that's being conducted by some early career researchers. Most of us, I think, are aware that CRPS is quite difficult to investigate because of its complexity and also its rarity. So every research effort is really, really valuable. Today's presentations will be quite clinically focused, but they will vary in scope, ranging from the co-design of patient resources to body disturbances in CRPS all the way to prognosis. We have 4 expert early career researchers presenting today, and each of them have a wealth of knowledge on CRPS. And we really hope that you'll find today's presentations valuable, either in informing your management of CRPS or for your own CRPS research. And as Greg said, we have quite a busy program, so we won't be taking questions until after each talk. But we do have some time for questions and discussion at the end of the presentations. And again, as Greg mentioned, that discussion will be co-moderated by Dr. Janet Bultitude and joined by other CRPS SIG committee members. So without further ado, I'd like to introduce today's First speaker, Dr. Monica Halitska. Monica is a Senior Research Associate in Evidence Synthesis at the University of Bristol. She completed her PhD at the University of Bath and held postdoctoral roles at the University of Liverpool and UC Louvain. Her research is broadly focused on applying experimental psychology and statistical modelling approaches to acute and chronic pain. And her research is also focused on working memory, spatial attention, body representation, and sensory motor adaptation in healthy individuals and people with CRPS. Today, Monica will be presenting on visuospatial attentional bias in complex regional pain syndrome. Thanks, Monica. Over to you.
Thank you. Let's just share the slides. Okay, so just let me know if you see
Yeah,
the
looks good.
slides. All good.
It's
okay.
fantastic.
Okay, so let's just get started then. So there's a little spoiler in the title of the talk in terms of the results of the study I'm going to present, but let's just start from the beginning. So we know that apart from pain and other sensory, autonomic, and motor signs and symptoms, CRPS is also associated with some neuropsychological changes. And these often include a distorted cognitive representation of the affected limb, for example, in terms of its size, shape, and even sense of ownership. And people with CRPS also present with reduced attention to the affected limb and its surrounding space. So, for example, they can be slower in processing the information presented on the affected limb relative to the unaffected limb. And these symptoms resemble sort of neglect syndrome that can occur after brain injury. And in some studies, these neuropsychological symptoms have been associated with the severity of pain and other clinical symptoms. So this may be an important angle for understanding the complexity of CRPS and even developing new rehabilitation approaches. But first, let's unpick when and how this attention bias actually manifests in CRPS. Because more recent evidence has actually been painting a bit more complex picture, even suggesting that spatial attention in CRPS is rather evenly distributed. And one reason behind these mixed findings might be that the attention bias in CRPS is only present or is more prominent under specific circumstances. So, for example, in situations where the task-related information is directly relevant to the patient's body or specifically to their CRPS-affected limb. And this idea has been called somatospatial inattention. So, for instance, people with CRPS would present with an attention bias away from their affected side when the task stimuli are presented directly on their hands, so in their personal space, or right next to their hands, so in the very personal space. Then, in contrast, we tend to find no bias when the task stimuli are presented in the same physical location, but the hands are out of participants' view or they are separated from the stimuli by a physical barrier, or when task stimuli appear much further away from the body, so in the extrapersonal space. So it seems like in most cases, reduced attention to the affected site is found only when task stimuli are presented on or very near to the body. And this sort of suggests that attention bias in CRPS may be limited to personal or peripersonal space. Now, if this is the case, and perhaps what drives the attention bias in CRPS is this interaction between spatial and body representations, then the bias should be stronger or even limited to the affected body part compared to other limbs, because we know CRPS usually would affect one specific limb of the body. So to test whether the attention bias is specific to the affected body part, we measured spatial attention in the region of hands and feet in people with lower limb CRPS and upper limb CRPS. So we hypothesized that lower limb CRPS individuals would show greater attention bias when tested on their feet versus hands, whereas upper limb CRPS individuals would show a larger attention bias when tested on their hands versus feet. Now, how exactly did we measure spatial attention? So we used a temporal order judgment task where we present pairs of brief light flashes on top of participants' hands or feet, so in their personal space. And the two lights flash with a range of different onset asynchronies. So, for example, light on the left hand would flash first, and then 10 milliseconds later, light on the right hand would flash. Then participants report which one of the two lights they perceived as flashing first, left or right. Then we'll take the proportion of their responses that the light on the right flashed first, fit a psychometric function, and derive the threshold of this function called point of subjective simultaneity, which is essentially our index of spatial attention bias. And how we could interpret this is that, for example, fewer right first responses would result in a positive PSS value, indicating reduced attention to the right side. So we recruited 3 groups of participants matched for age. I already mentioned the lower limb and upper limb CRPS groups, but you can see that we also had a group of pain-free control participants. So why are controls important when we're testing for biases in spatial attention? The reason for this is that the attention is normally not equally distributed between two sides of space, and instead we have a slight leftward bias in attention called pseudo-neglect. So to demonstrate whether CRPS is associated with changes in spatial attention, it's not sufficient to test the attention against perfectly balanced distribution of attention. But if we're interested in whether there's a change or deviation from the norm or from how attention is distributed in non-clinical population, then we need this non-CRPS control group. And you may remember from the task that participants are making left versus right judgments about the order of the stimuli, but we're actually interested in any bias relative to the CRPS affected side of the body. So we re-express participants' responses according to the side of their affected limb. And since the pain-free controls don't have an affected side, we take their non-dominant side to correspond to the CRPS affected side. So each group completed the temporal order judgments in both body regions where the stimuli appeared on the hands or on the feet. And just to note that the hypothesis methods and the analysis plan were pre-registered on Open Science Framework, and the study data is also available there. Now let's look at the results. So we haven't found the interaction between group and the body region that we were expecting. There was also no overall effect of body region, meaning that the attention bias did not differ between the hands and feet. But we can see some overall group differences, which are represented here, so kind of collapsed across the body regions. So we can see that the control group had quite positive PSS, indicating increased attention to the non-dominant side, which essentially will be consistent with this sort of neglect or leftward bias because they were right-handed. And then compared to the controls, you can see here both lower limb and upper limb CRPS groups had less positive PSS, which means reduced attention to the affected side. But like I mentioned, irrespective of the body region. So people with CRPS showed reduced attention to the affected side of the body that was not limited to the affected body part. So looking back to our hypothesis, we can say that regardless of where CRPS was located, patients had reduced attention to the affected side in the region of both hands and feet when compared to controls. So in this study, we additionally explored whether attention bias in participants with CRPS was associated with any clinical and psychological factors. So we found a strong negative relationship between the attention bias and CRPS symptom severity. So you can see, for example, that patients with less severe symptoms had more positive PSS, so they were in a way more similar to pain-free controls. And the more severe the symptoms are, the less attention patients pay to their affected side of the body. We found no associations with other factors like the duration of CRPS, pain, body representation distortions, or fear of movement. And so let's summarize what we can conclude from the study. We can say that relative to pain-free individuals, people with upper and lower limb CRPS pay less attention to visual information on the affected relative to the unaffected side of the body. So among the recent mixed evidence for neglect-like bias in CRPS, this study would support the conclusion that people with CRPS do present with reduced attention to the affected side in personal space, so when the task-relevant information is presented directly on their body. And this attention bias is not limited to the CRPS affected part of the body, but it rather appears to generalize to the entire side of the body ipsilateral to the CRPS affected limb. So we initially expected this attention bias to actually depend on which body part is affected, upper or lower limb. To some extent, this was based on this supposed interplay between spatial cognition and body representation, since usually the distorted body representation is limited to the CRPS affected limb. And then it would not affect other parts of the body as much. And in this study, participants did report body perception disturbances for their CRPS affected limb, but these were unrelated to the magnitude of the attention bias. So instead, the attention bias seems to manifest within the personal space, which covers the whole body. And this brings us back to the analogy with the neglect syndrome in brain lesion patients, who can also show neglect in personal space without any attention biases in other regions of space. So it is possible that it's the case of this sort of isolated neglect in personal space. This is pretty much everything I wanted to say about the study. I would just note that the study was conducted at the University of Bath, so I would like to just thank my colleagues, Olivia, Tony, Axel, Michael, and Janet. And it seems like it was pretty good timing with this webinar taking place, because the complete article describing the study has been very recently published, so you can find a QR code here and the title. And if you do have any questions about this presentation or the study, please do feel free to email me, and I will happily answer any questions. Thank you.
Thank you very much, Monica, for a fantastic talk, and it certainly is timely with the release of your paper. So Monica might not be able to remain for the entirety of the discussion session, but as she said, she can be contacted via email for any questions, and we'll also have Janet, who was a co-author on the paper, who can help out with answering them. So thanks once again, Monica. Our next speaker is Caitlin Naylor. Caitlin is a PhD researcher in the Department of Psychology at the University of Bath. Caitlin's PhD investigates body perception disturbances in chronic pain with the aim of creating a new approach to CRPS rehabilitation. Today, Caitlin will present on variability in body perception disturbances and how this can inform personalised virtual reality rehabilitation. Thanks very much, Caitlin. Over to you.
Thanks. I'll just share my slides. Oh, is that all okay?
Yep, looks great, Caitlin.
Great. Okay, so yeah, thank you very much for having me today. I'm very excited to be able to talk to you about my PhD work. So yeah, today I'm going to be focusing on characterizing and understanding the differences that can arise in body perception disturbances in CRPS, and how that can inform approaches to rehabilitation. So yeah, Michael gave a lovely introduction, but very briefly, I'm in the third year of my PhD at the moment. And my PhD focuses on body representation distortions in both health and chronic pain. But obviously today I'm going to be focusing on chronic pain. I'm focusing on the main goal of my PhD, which is to create a virtual reality-based body perception disturbance rehabilitation tool in CRPS. So yeah, today is going to be talking to you a little bit about the development of that tool and where we're at with it now. So a little bit of background. So we understand that we have lots of different representations of our body in the brain. And these sort of body maps, as people sometimes call them, have to all be combined. And when these are integrated, it forms our sort of conscious experience of our body. Which for most people, that experience is sort of coherent and singular and makes sense to us. But for some individuals, their perception of their body doesn't make sense to them. It can become distorted or altered. And whilst the exact mechanisms for this is still being explored, it's broadly thought that what happens is across all of these different body maps that have to be combined, some errors or changes to those body maps occur, which means that when they're combined, they no longer agree with each other. So these sort of conflicts arise, and that incongruent information is then combined, and that sort of manifests as a conscious experience of a disturbed body perception. And these body perception disturbances are very common in CRPS. So we're still trying to understand why exactly they occur and how they occur, but it's fairly well established that they do occur, and that they seem to be quite important. So a range of studies have shown that they correlate with important CRPS symptoms like pain intensity or CRPS severity, sensory motor changes. And so it seems like it's worth continuing to explore and understand this aspect of the experience of CRPS. So in terms of the types of body perception disturbances that can arise, we see a lot of variability. So if you look across lots of different literature, of large experimental work, all the way down to case studies, we see that there are a range of different features of the limb that are affected, such as shape, size, position, as well as different modalities. So, for example, patients might report that the visual appearance of their limb appears to be different from how it actually is or how they think it should be. Or they might report that their limb feels wrong. Or it can also affect your mental representation. So if you ask patients to close their eyes and describe their limb, they might describe it as being distorted in some way. They might even describe it as not appearing to be a limb at all. They might describe it as appearing as if it's a bit of wood extending from their shoulder. So the range of distortions can really vary. And that's fairly well established, but what's less clear is whether this variation is important. So all of these different ways in which the disturbances can manifest, is this information useful for understanding, diagnosing, treating CRPS and the related body perception disturbances? So that's one of the sort of aims that my initial PhD work aim to figure out. So we saw all of this variability, all of these different aspects of body perception can be impacted. But we wanted to understand partly, does it matter? And also, how exactly are we defining and characterizing these disturbances? So across the literature, it's sometimes spoken about as a discrepancy between the appearance of the limb and the way it feels, but also it could just be that the perception of the limb is disturbed compared to how the individual feels their limb should be, or how they're used to it being, perhaps before their onset of CRPS. So we're trying to understand how best to sort of define these disturbances and whether that can help us to categorize some of this variability that we see. So that's what we aim to do. We conducted a large survey study of 115 people with CRPS. We looked at a range of different questions. It was a very exploratory survey that I wouldn't have time to cover, unfortunately, in full today, but I'm just going to focus on this distinct aspect for now. So we asked people with CRPS to think about their perception of the appearance of their limb compared to what they thought their limb should be like, or what they thought a typical or normal limb would be like. We also asked them to do the same thing regarding their feeling of their own affected limb. And then we actually compared their responses to get an idea of how well the visual perception and the felt perception of the limb corresponded. And by doing this, we were able to group the participants in our study into 3 distinct categories to sort of try and organize all of this variability. So we did indeed find that the extent to which the visual appearance or the feeling of the limb was distorted did vary a lot across our group, but we did find these 3 categories. So for the first category, this one here, we found that 58% of our group had quite quite strong disturbances to the perception of their limb, but it did sort of vary within the group. But importantly, they had good agreement between the appearance of their limb and the way it felt. So even though their modalities were sort of in agreement, they were still experiencing this disturbance to the perception of their limb compared to sort of how it should have been or how they thought it should be. Then we had the second group, which was 32%, and these were just individuals who experienced some disturbances to their body perception, but nowhere near as strong as the other groups. So this just highlights that the extent to which these disturbances exist in CRPS in itself does still vary. And then the final group, which was just 10% of our sample, found that they had a disagreement between their perception of their visual appearance of the affected limb and the way their affected limb feels to them. And actually, most of the individuals in this group were reporting that the way their limb feels was significantly more distorted compared to the way that they perceive it looks. So yeah, this shows us that these sort of distinctions in terms of the conflicts across the modalities, as well as the way that you define disturbances as a different from normal, both of those were useful for categorizing the participants in our survey. Then we had a sort of second aim from this survey, which was to understand another aspect of variability that we see within the literature around body perception disturbances in CRPS. So within this literature, we see that when people are trying to treat or rehabilitate body perception in CRPS, usually methods are used to normalize the appearance of the limb. So there's different visual manipulation strategies, such as mirror therapy or just simple visual illusions. And most of them do aim to replace the visual information about the limb with sort of normal visual cues of what you would expect an unaffected limb to look like. But some recent work by Lewis and colleagues showed that when they showed patients their desired limb appearance in virtuality, so they asked patients, what would you wish your limb looked like? And then they created this representation in virtuality, and they found that when patients embodied this desired hand, they found improvements to both pain and body perception. So this got us thinking about, you've got these classic normalization methods to treatment, which show mixed effectiveness. And then you've got this sort of new idea about what patients desire. So we were interested to understand a little bit more about what patients desire to see if there's some other ideas for rehabilitation that we should be taking into consideration. So in our survey, we asked people, firstly, whether they wanted to change the appearance or feeling of their limb. And then if they did that, would it make their limb look more or less like a typical limb? And again, we found 3 distinct groups emerged when we used cluster analysis. So for this, I'm going to actually point your attention to this middle group first, because it's maybe the slightly more expected one. So we found that this group did in fact desire to change their visual appearance and the feeling of their affected limb. So with this dark blue box here. And sort of as expected, they said that if they made these changes, then their affected limb would very much resemble a normal limb again. And interestingly, 22% of the group had very strong desires to change their perception of their affected limb. But actually, they reported that if they made these changes, their limb would not at all resemble a typical limb. So whatever changes they want to make, which is something that we want to explore in future work, whatever changes they wanted to make, that would not result in their limb being like a normal limb. And then we have this final group, which was 39% of the group. And they reported that, again, they wanted to change their limb. And whilst they had a bit more variation, they still didn't just simply want their limb to be normal again. They had a sort of variety in terms of the extent to which they desired normalization. So this tells us that it's not enough to just assume that the way to rehabilitate and treat body perception disturbances in CRPS is to simply make the limb look normal again, because that doesn't fit with what patients are telling us. So both of these insights we sort of see to have quite important repercussions for rehabilitation. So first of all, it seems that different representations of the body can become disturbed in CRPS, and the sort of conflicts that arise between our different perceptions and modalities of our body, these conflicts can crop up in different places. So it sort of makes sense that if the type of body perception disturbance can differ for different individuals, then the way that you rehabilitate that body perception and achieve that sort of coherency within your conscious experience of your body will differ for different patients. Another sort of insight from these results is, as I mentioned, it doesn't seem that all patients want their limb to look normal. There definitely are a group of patients who say, please just make it normal again. But there's other patients who actually desire something different. And we think it's definitely worth understanding what these differences are and what exactly they're desiring, but also bearing this in mind when we're designing rehabilitation. And so we see that patients do actually have these very specific representations and ideas of what they want their limb to look like, and we think that's worth utilising. So at the moment, we're developing a virtual reality-based rehabilitation tool. And this tool allows people to embody human-looking hands in virtual reality. So they're in full control of the movements of the hands. But we can manipulate the visual appearance of the hands in very sort of standardized and specific ways. So you can see from the videos just some of the examples of the changes we can make. So we can make the hand globally very big or small. We can make changes to specific fingers. We can remove fingers entirely. So we really can do a range of different things, and there's much more than I had space for on my screen to show you videos. But the important thing is that we're developing the tool to be able to be easily altered. So obviously, personalized rehabilitation always sounds great in theory, but practically it's quite difficult, and the feasibility of it, isn't necessarily as strong as the idea of it. But the nice thing with VR is that you can create a sort of base tool that can then be altered in a quick and easy way to fit each individual patient. So you sort of start off with the same thing, but then you can personalize it a little bit for each patient. And that's exactly what we plan to do. So at the moment, we're preparing to run some PPI workshops with people with CRPS. And they're going to be able to test out this VR rehabilitation tool that we've created and tell us what they think about it. We're hoping that they're also going to be able to give us some insights into whether we've missed any features that they would like to edit. So we're going to talk a bit about their how they desire their limb to look, and see if there's certain features that we currently can't edit that they think are quite important. So for example, at the moment, we're trying to work on being able to edit the sort of shape of the palm and things. So yeah, just little changes like that that we might not have considered. Then when we're happy with the tool, we're going to first run one-to-one sessions with different patients, so that we can basically create personalized hand models for them. So we'll be aiming to create a version of the VR hands that match a normal hand, or what that patient considers to be a normal hand. We're going to create a version that matches their mental representation of their limb, so that we can sort of create an agreement between the visual cues and their mental representation or feeling of their limb. And then we're also going to create a version that is simply what they desire it to look like. Then after that, we'll test out these 3 different hand models and see if it impacts body perception, pain, and motor functioning. And importantly, we'll also hopefully be able to look at whether there's any relationship between the existing body perception disturbance and the most effective hand model out of the 3, to see if that can sort of explain why some treatments are more effective than others. So yeah, obviously that was quite a whistle-stop tour, but generally the message that hopefully you've picked up on is that there is a lot of variability in body perception disturbances, but that variability can actually be very useful, and sort of can be characterized in a way that can help us to better understand these body perception disturbances, and in a way that can inform the design and the use of different rehabilitation strategies. Thank you very much for listening, and if anyone has any specific questions that they don't have time to follow up on in the Q&A, then I'm very happy for anyone to reach out via email or on Twitter. Thank you very much.
Thank you very much, Caitlin. That was an absolutely fascinating talk and certainly a look to the future. I know I'll have plenty of questions for you in the Q&A. So our next speaker will be Dr. Colleen Johnston-Devon, who is also joining from Australia. Colleen is a senior lecturer in the School of Nursing, Midwifery and Social Sciences at CQ University, currently teaching research units in the Master of Clinical Nursing program. Colleen's research areas include persistent pain, chronic condition self-management, ageing, lived experience, person-centered care, and research methods. Today, Colleen will be presenting a community-driven project to establish the information needs of people living with CRPS. Many thanks for joining us so late in the evening, Colleen. Over to you.
Thank you, Michael. And since you've said that I'm in Australia, I'll just add that unlike you in Sydney, I live at the Sunshine Coast and it's beautiful. So I'll just say that. Now, can you see my screen properly?
Yes, I'd like to be where you are, Colleen, and we can see your slides, no problem.
Everyone wants to be where I am. I'll just get that out of the way first. So my talk is quite different to the other presentations that you'll hear. Because my work is qualitative and my work stems from the fact that 14 years ago, that was my hand. So I was playing softball and somebody ran into me and I developed what's called a stena lesion. So the ligament in my thumb was completely ruptured. To cut a long story short, I was diagnosed with CRPS. Now, I was very lucky that I was diagnosed very quickly, and because I was working as a nurse at the hospital, I had a lot of people helping me. So I was very, very lucky in comparison to a lot of people. Once I was diagnosed, I didn't like that idea, so I had a second opinion. Then I got another second opinion and another second opinion. I was told, yes, you have got this condition. I was told to forget about it. So, of course, I went and looked it up. Nobody could tell me how to live with this thing. If I can just move my thing. Okay, so the first thing I did was I went online and looked up everything I possibly could. Now, I'm not going to name sites or name different groups or anything because everybody has their place and everybody has good information, but you can also get a lot of bad information. But when I went online, I learned that there's no cure. It can go into remission, but it can reoccur with further injury, that full recovery is uncommon. Now, that sounds pretty scary. It can spread to other body parts, apparently including internal organs and teeth, and there's something called full body CRPS. And you'll see people in a lot of the Facebook groups talk about full body. I learned that diagnosis can take years, that it can result in amputation, and its nickname is the suicide disease. Now, recently I was looking online preparing for this talk, and apparently almost 50% of people diagnosed with CRPS will think of suicide and 20% will attempt suicide. Now, I'm not saying that this information is correct or incorrect. What I'm saying is this is what some people truly believe, and this is what they're posting. So a lot of other people see this sort of information. The narrative online also is that doctors don't get formally educated about it, that it happens for no reason to people of any age. There's reports that suggest that 75% of CRPS sufferers have dental issues, and they're very often serious. And there was a post recently about somebody that went, oh my God, I've got a toothache. I don't know what to do. And the comments following that were really quite scary. This person was scared that they had a toothache and she's got CRPS, and it was like the end of the earth, which is an awful position for that person to be in. Another thing, I don't know if you have that in other places, but in Australia, we get, unfortunately, on news and current affairs programs, the narrative for paediatric CRPS at the moment is that there's just nowhere in Australia that you can go, and you have to go to the Spiro Clinic in America, and that often involves mortgaging your house. And unfortunately, people do that. So this is the state that some people get into. So the other thing that you see when you go online is the McGill Pain Index. And this clearly shows CRPS is the worst pain in the world. It won't matter what site you look at, you'll see some form of this questionnaire, which comes from Katz and Melzak back in 2003. That's the earliest image of this that I could find. I've never found it any other place, but I think this is where this information comes from. So once I knew all of that sort of thing, I wanted to know, well, how do people live with this? Like, there's excellent research all over the world, and we've heard from some already, and we'll hear from more tonight. There's really, really good work going into diagnosis, to management, to treatment, all sorts of things. But no one could tell me, how do people live with CRPS? So I did a PhD and I found out. In a nutshell, my PhD project found that the essence of CRPS, the essence of the experience of CRPS, is that it's a battle. So there's many things that fit within the battle analogy. When I interviewed people, so many of the participants talked about a battle. I was interviewed for my own project. We'll go into the phenomenology aspects in a different presentation, but I was interviewed as a participant myself, and I used the word battle, and it wasn't until the battle was pointed out to me and I went back that I went, wow, I've used the same words myself. So people go through things like dealing with an unknown enemy. So that's because it's rare, it's largely unknown. Multiple terms are still used. People often have poor health literacy. It's difficult to diagnose. You get different bits of advice. The next section is building an armory against a moving target. So again, we don't know exactly what causes it. We don't know why some people get CRPS and some people don't. We don't know why medications can work and then cease to have an effect. But there's also the battle between quality of life and medication side effects. So for example, I remember at one stage, I had to go and pick my children up from school, but I was in so much pain, but I couldn't take anything, any extra pain relief, because then I wouldn't be able to drive properly. So there's a lot of things that need to be balanced. There's the spread and fear of spread. And can I tell you, I don't have many symptoms with my hand at the moment, or haven't for a long, long time. Don't take medication or anything. But when I ruptured my ACL last year, my first thought was, this can spread. And I went to my pain specialist and said, this can spread. This isn't helpful thinking. This sounds catastrophic, but, and he went, you're exactly right, Colleen. And now it's better. It didn't spread. I know it's not going to, but that's the headspace you get into. If we look at battles within the war, we get to things like how difficult pacing is, how easy it is to overdo. People feel guilty because they can't perform their normal roles as the family member or the moneymaker or their work role or whatever. They feel loss of their previous life or parts of their life. There's the financial considerations. There's judgment if you take opioids. If we get to developing battle plans with allies, this is when people have to advocate for better treatment quite often. They need the value, they need to recognise the value of multidisciplinary teams. They need to find really good health professionals to help them, and they need family support. And so you find a group of people that can help you navigate your new life or your changed life. The last one is warrior or prisoner of war. And this is where people hide behind a mask and they pretend they're okay. So that's the fake it till you make it. You don't tell anybody how bad you really feel because people won't believe you. There are people that lock themselves away forever. I know somebody that's still to this day, after 4 years, sleeps on a chair because she's too scared of her husband rolling over in bed and touching her leg when she's asleep. I consider that not a great way to live. It works for her. And the opposite of that is unleashing your inner resilience, so unleashing your inner warrior, harnessing your resilience factors and having this existence where you're in control of the CRPS versus it controlling you. So with all of that in mind, I knew that I had something, but I needed to work out how I'm going to help other people. So I understand what it's like to live myself. I understand what it's like to live from other people, but how are we going to harness this knowledge and help others? So this led to the study, Meeting the Needs of People Living with Complex Regional Pain Syndrome, Defining the Problem. As you can see, we had a group in this research team. So there were 3 of us from CQ University. We had somebody from the University of Sunshine Coast. Renee Rankin is the CEO of Chronic Pain Australia, and that's a support group in Australia. They've just merged with a different group, Australian Pain Management Association. They have a lot of support services like helplines, that sort of thing. They do a really good job. We also partnered with CRPS Awareness, the Purple Bucket Foundation. Now, that's the only registered CRPS charity in Australia. We had Kim, who's the president of that, and Jan, who's one of the members. So on our team, we had 3 of us with CRPS, Renee with a huge understanding and lived experience of chronic pain, and one of the other research team members also lives with chronic pain, but not CRPS. So we were funded by a CQ internal research grant. We got ethics approval. We interviewed 20 people, basically asking them, what are your needs? What do you think will help you live with this condition? With our mix of people, we had 16 female and 4 male, age range of 24 to 73 years. Interesting, the range of experience was from 1 to 30 years. And the information that they told us didn't really change between the age, the length of time with the condition, where they lived, where their CRPS was, or even with their education level. So it was really quite an interesting study to look at and to analyse. Okay, so interestingly, people said really strange things again. So apparently CRPS affects the GI system after 5 years. Wherever you've got a nerve, you can have a complication. Stage 4 results in cancer, and it's actually caused by mast cell activation and histamine. And it amazed me that I first started looking at this 14 years ago, and even now people are telling me things that really aren't true. It doesn't result in cancer, but these are things that people truly believe. The other comments that I found quite sad, I don't have a lot of faith in the health system anymore. Literally no one I can speak to. I've never got any information. I was told to Google it, and this word suffer kept coming up. I'm a sufferer. I'm suffering. Us CRPS sufferers. So we really need to change the narrative around this. So apart from these false narratives, people are saying things like, don't shave your legs because if you cut your legs, you're going to get a spread. So we knew from all of that that we needed to act properly. We needed to have something that's going to really help people. So the overwhelming thing that came out was people want specific CRPS information and education. They want it at the time of diagnosis or the time of suspected diagnosis. They want something simple and easy to understand that they can take home. They also want something online so that they can tell other people to look it up. As they go down the track and have CRPS for longer times, they want more detailed information. We knew that it had to be couched in positive language to get rid of this sufferer, suffering, worst pain in the world narrative. We wanted to give people hope because the one thing that we do know is that most people improve. And that's really difficult information to find on any of the websites. We know that it needed to be trauma-informed and it needed to be recovery-oriented. So we've actually made a brochure. The result paper is still in progress because patients really don't care about what my H index is. They just wanted results from the work that they did. So our brochure design was co-designed with our industry partners, with all of the research team. So the participants gave us the information. They're actually the ones that told us they want the brochure. It was written initially with academics and then the industry partners. We showed it to a lot of people with lived experience. Then we showed it to some clinicians, and every time we showed it to a new person, the brochure changed. Once we had the wording, we gave it to a multimedia developer who did all of the things that these sort of people do graphically to make it look very, very nice. So this is our brochure. This is the first page. The colours were a different, slightly different colour orange. Orange is the awareness colour for CRPS. It was a different shade of orange, but it came through one of those readability checks that the colours needed to be changed, the fonts needed to be changed. We have got written on this is a draft brochure. We know that it can be improved. So please, any of you out there watching this, please contact us if you've got any ideas for how to make it better. This is the second page of the brochure. We've got things like under, is there a cure? Well, no, there's not. But we also say there's no cure for diabetes or the common cold. So we're saying the truth, but we're putting it into some perspective. We're saying that you'll learn to manage your symptoms. We're saying things like you need help from health professionals. So what we're trying to do is harness the power of the individual to start acting, working towards helping themselves, knowing that there are people that they can go to. So future work, you'll see on the first page of the brochure, we've got a QR code. So eventually we want people to click on that QR code and link to information. And this is where I'm appealing to everybody here. All of you have got expertise that we can use. Michael's very kindly agreed to write me a lay version of his recent Lancet article. We want information about sleep, spread, managing a flare, cooking, shopping, dealing with brain fog, anything that you have already published. If that can be made into a lay version that's suitable for anybody, we want it, and we'll put it up on our site so that when people click on that link, they've got a resource of really credible information to go to. So I know Dr. Gobel is in the room now. This fits in with the patient information and education section of the guidelines that he's first author for. And it's must receive adequate information soon after diagnosis. This is one way that we can actually meet that standard. Provision of information is by all therapeutic disciplines and must be repeated as appropriate. This is where the research team know we need other experts from around the world to tell us what else we can do. So far, the brochure's been disseminated to GPs around where I live, the Queensland Persistent Pain Clinical Network, which is every persistent pain clinic in Queensland with public hospitals. It's gone to a few private pain specialists. Chronic Pain Australia have it. Purple Bucket Foundation have it. Public Health Network in Hervey Bay, which is a region of Queensland. I run a CRPS social group and they've all got it, and they're giving it to every health professional that they access. The brochure has been presented at the Australian Pain Society conference. I'm telling you all about it now, and it will also go to Pain Nurses Australia conference. Hopefully down the track, we will be able to alter the brochure for perhaps other countries, and we can also adapt it to suit other conditions. And if anybody's interested, that's my references. And I'd like to thank you all for persisting with me with my very naughty mouse, which I think is the problem.
Thank you so much, Colleen, for an excellent talk, and your unique perspective on CRPS is absolutely invaluable, and hopefully we can all help to circulate your information brochures. Okay, so now just to introduce our final speaker, Dr. Marc-Henri Louis. Marc-Henri is a third-year PhD student working on prognostic factors in CRPS. After graduating as a medical doctor in 2022 at UC Louvain in Belgium, Marc-Henri commenced a PhD and currently works part-time in a pain clinic as an intern. Today, Marc-Henri will present preliminary results of an ongoing prospective cohort study that assesses early prognostic factors in CRPS. Thanks, Marc-Henri, and over to you.
Hello, thanks for the invitation. Okay, hello everyone. Thank you for being here. My name is Marc-Henri Louis. I'm a PhD student working in Belgium. I'm in my third year and I'm working on early prognostic factors in CRPS. I'm going to tell you what we have already done on this topic and what we are planning to do. So, and I remove this. Okay. First of all, why early prognostic factors? The idea is that if we know the early prognostic factors of a condition, we would be able to classify patients according to their risk of chronification, the risk of developing a chronic condition. Then we could adapt our therapeutic management to try to reduce this probability. If we consider another painful condition, for example, low back pain, we have some clinical tools to predict which patient may develop a chronic pain condition. This depends mostly on psychosocial factors, also known as yellow flags. What do we already know about early prognostic factors in CRPS? We have published a systematic review on the topic, and in short, there is a huge lack of knowledge and research on the subject. We identified 6 factors, but these are mostly based on only one longitudinal study. One way of stratifying patients is to identify the subtypes of a condition. This could explain the variability in treatment response and prognosis in CRPS. Some of you probably know that there is a recent systematic review on the topic. They found 25 studies which identify 7 potential classifications, mostly based on t-test or equivalent. So just keep in mind for the presentation that there are potential subgroups in this condition, but nothing is clear for now. Quantitative sensory testing is commonly used to assess some of these potential subtypes. The idea is to assess patient sensory profile without any invasive measurements to evaluate their sensitivity to thermal, mechanical, and vibratory stimuli. A recent systematic review reported in summary that patients with CRPS appear to show a gain of function for painful stimuli and a loss of function for non-painful stimuli. Here is an example with the loss of function and in purple, the gain of function. Similar disturbances can be seen on opposite sides, as illustrated in this figure in black. So, based on all I've presented, we started a longitudinal observational study in April 2022. The first objective is to evaluate the evolution of early CRPS, defined in our study as less than 6 months after the onset of the condition. Secondly, we want to examine the role of biopsychosocial factors in the development of persistent CRPS. The final aim is to evaluate if it's possible to stratify patients according to their risk of chronification and to propose a personalized therapeutic management to reduce this probability. Here is the study design. We included patients as soon as possible after the onset of the condition, and we follow them during 12 months. There are 4 assessments, and each time we perform the same, we collect the same data in 2 sessions. The first one is a face-to-face assessment, and the second one is a survey that the participant is completing at home. Inclusion has ended in December 2023, and the study is still ongoing. We are planning to complete it in December 2024. So what variables are studied? We try to cover the biopsychosocial model, so we assess some demographic and clinical data, for example, work-related variables, medical history and comorbidities, CRPS presentation, current treatment. We also perform a quantitative sensory testing. For the cognitive deficits, we used a questionnaire, the Revis-Bars CRPS Body Perception Disturbance Scale, and a visuospatial attention task, like Monica did. Finally, participants complete questionnaire at home to assess disability, quality of life, and pain, and other questionnaire for the biopsychosocial model. The primary endpoint is the disability, and we have secondary endpoint, return to work, CRPS severity score, quality of life, and pain. Here is the flowchart. We included 113 subjects, and we have currently a very low rate of dropout. Regarding the demographic characteristics, the cohort is mainly, female, with a mean age of 53 years old. The patient recruited mostly suffered from an upper limb CRPS, and the mean duration at the inclusion was 76 days. 2/3 of the subjects were working before the onset of the condition. For the CRPS features, 1/4 of the subjects reported a family or personal history of CRPS. For the triggering event, it was either a soft tissue injury, an elective surgery, or, most of the time, a fracture or a major trauma. Only 10% of the cohort were classified as CRPS type 2, and 80% of them met the Research Budapest criteria. In terms of cognitive assessment, our cohort shows body perception disorders similar to those of the cohort used to validate the Revis-Bas CRPS body perception disturbance scale, mainly composed of persistent CRPS. We can therefore hypothesize that patients with early stage CRPS show similar body perception impairment, and that these disturbances are not merely a consequence of long-lasting CRPS, but may play a role in triggering or maintaining CRPS. For the visuospatial attention task, we did not identify any systematic bias toward the affected limb or the contralateral limb. There was also no correlation between the computed bias and the body perception score. With regard to QST abnormalities, our results were similar to those previously reported, with a loss of function for detecting non-painful stimuli and a gain of function for thermal painful stimuli and blood pressure. At the opposite, our cohort showed no significant gain of function for painful stimuli, mechanical pain sensitivity, and mechanical pain threshold. On the basis of exploratory analysis, we identified significant differences between participants according to the physical severity of the triggering event, the limb involved, and the Research Budapest criterion. At the opposite, no real differences were observed between subjects according to the sex, the family or personal history of CRPS, the skin temperature, or even though some of these factors are reported as potential subtypes in the literature. To take this a step further, we perform a latent class analysis, which is a more robust and objective cluster analysis than classic clustering, for example, k-mean or two-step clusters. It requires the inclusion of variables associated with pathophysiology rather than outcomes, for example, quality of life or disability. It's a work still in progress, but based on the putative physiopathology, we selected the following variables. For the sensitization, the PPT, and the presence of allodynia. For the inflammatory response, the physical severity of the triggering event. Unfortunately, we didn't have any data to have access to any genetic predisposition or biomarkers of the inflammation. For the psychosocial risk of chronification, we used the Orebro. For the vasomotor dysfunction, we used the skin temperature. And for the cognitive disturbances, we used the Revis-Bas CRPS body perception disturbance scale. First, we observed that the skin temperature did not influence any model, so we chose to remove this variable to increase the power of the analysis. Then, we found that the best model was the 4-cluster one. We named each profile as mild CRPS, moderate CRPS, severe CRPS, and pressure allodynia CRPS. We observed that the following parameters were associated with poorer outcomes in this cross-sectional design at the inclusion: the presence of allodynia, higher Orebro score, higher body perception disturbance score, lower PPT, and lower physical intensity of the triggering event. It should be noted that for the last one is the opposite of previously reported in terms of prognostic factors. The reason behind this result still need to be explored. Here is the different component of the model. We observed that for the pressure allodynia CRPS subgroup, it was defined by higher Orebro score, more minor trauma as triggering event, and higher PPT score. For the severe subgroup, they have the highest body perception disorder score and weight of allodynia. Finally, for the mild and moderate subgroups, the triggering event was similar, mostly some fracture or some traumas. Just to have a look on the outcomes, in brief, mild CRPS presented better outcomes than moderate CRPS, which presented better outcomes than the two others. Severe and pressure allodynia CRPS subgroups presented similar outcomes. First, our results need to be replicated in another cohort. Then, the significance of these potential subgroups in terms of pathophysiology, prognosis, and treatment needs to be explored. Our longitudinal study will attempt to answer this question. Of course, your opinions are most welcome. To conclude, early prognostic factors in CRPS are unknown, are a crucial field of research. The aim is to be able to stratify patients and to develop a personalized therapeutic management. Early CRPS can be divided into subgroups presenting different outcomes: pain, disability, quality of life. They present similar body perception disturbances as persistent CRPS, and they did not present significant systematic visuospatial attention bias. Thank you for your attention.
Thank you so much, Marc-Henri, for a fascinating presentation, for your work on such an important and much needed study. So we've had a really nice summary of some exciting CRPS research, but we just want to take a few moments now, probably 20 minutes or so, to explore each presentation further. So we'll move to the discussion session, which will be co-facilitated by Dr. Janet Bultitude, and I believe our other SIG committee members with us, so Professor Heike Rittner, Professor Andreas Goebel, and Professor Ji Yoon Moon to help us with the discussion. Do we have any questions in the Q&A, or would anyone like to lead with one?
So Heike, you have a question.
Yeah, this was beautiful work. I was very much impressed. Always excited to see what people do in CRPS. My question is actually concerned the first two talks, because you were looking at body perception. I was wondering, in your research, do you think that disease duration is an issue in your cohorts? This is the first question. And the second question is, do you think it makes a difference whether you have CRPS or, I mean, we have these patients that come with chronic pain of their wrist, but they don't have CRPS. Two questions. Is the disease duration an issue at all? Do you think so? Is it there right in the beginning? And the question is not the healthy controls, because I think they're too healthy, but the ones that don't have CRPS but chronic pain.
I'll let Caitlin answer first.
Yeah, please.
Yeah, I mean, quite honestly, I don't actually have many thoughts on those two particular questions. It's just not something that so far in my research I have looked at. I haven't particularly noticed any influence of disease duration. For example, on the survey responses, we did collect that information, and we did check to see if any of the data that we had, like for the example, those clusters, we looked to see if things like disease duration or like other aspects of the CRPS symptoms, like proportion of males and females and age and things like that impacted, and we didn't find that our specific variables had an impact. And then, yeah, I think the question about the non-CRPS pain patients was for Monica's work, so I'll let Janet take that one.
Yeah, so just to add to that, so generally the people who we access who respond to our research or take part in our research tend to be on the much more chronic side, which is why I was especially interested to see Marc-Henri's result that the body perception disturbances were comparable to some of the data that we've found as well in terms of severity of body perception disturbances. Neglect-like symptoms tend to correlate really highly with body perception disturbances, and one of the things that we are always considering is really whether these things are actually all that different, or whether actually the neglect-like symptoms really are just body perception disturbances, which is where Monica's finding that the neglect-like symptoms are generalized to personal space really ties into that, because personal space by definition is our body. That is what personal space is. So what she's found, if you kind of add it to some of the other findings from her own work, is that these attention differences seem to be very much about the body. So seem to be related to body perception disturbances. Marc-Henri has very much done a study that I was always very interested in doing myself. So I was really excited to see those findings. So I think that's enough.
Maybe, Marc-Henri, you can speculate about this.
To be honest, I don't have any idea. No. What is interesting in our studies is that we will follow the participant during 12 months. So we will see how is it improving or not, how is it changing, how is it correlated to pain or anything like that. But no, I have no real idea. I'm sorry.
And the patients that you included, how long did they have CRPS, or what was the distance or what was the time between the incident and when you started with the study?
We have the time between the inclusion and the triggering event, but we took the time between the inclusion and the beginning of the onset of the symptoms. So I asked to the patient, when do you think it beginning? If the patient was in a cast, for example, of course I didn't take this time, but yeah. So the duration of the CRPS is in terms of the onset of the symptoms.
And what was your inclusion period? Did you say like a year or 6 months, or how did you define that to include them, or there was no?
Less than 6 months from the onset of the symptoms.
Okay,
Unfortunately,
cool.
there's no clear cutoff in the literature for early CRPS. At the beginning, we wanted to include them less than 3 months, but it was a bit hard to find them.
You don't get them.
Thank you very much for a wonderful presentation and study for Marc-Henri Ruiz, Dr. Ruiz. I have a question about your study. You included 80% of CRPS male patients. So I wonder why usually CRPS happens to female patients a little bit more commonly, but in your study, a lot of patients were male. So what happened to your study? I wondered.
I'm sorry if I wasn't clear during the presentation. We have mainly females in the cohort, 77%, if I remember well, on 113 subjects. So it's like 80 subject of women. So yeah, it was most of the time women.
Oh, I see. I'm sorry. And also, the duration of pain was very short. So it's only 76 days, right? Yes. So I think that probably it's too short to diagnose CRPS, I think. What do you think? About this idea, thought.
It's an interesting question to you, and I often wonder that. I mean, I don't think it's been properly defined. Do any other of the presenters or panel members have strong views on that? Has it been characterized? Is there a clear cutoff?
I think most of the times we said the symptoms should be at least for 3 months after the incident, because this is when you still have a lot of processes going on, and if you have a radial fracture, this is what we use. And I think, Andreas, you have to correct me. I think this is what is written in the Valencia criteria. At least that's what I'm telling my residents.
Yeah, in the UK guidance, we said 1 month. It's hard in the first month to do it, and then it's sometimes not so easy in the first 3 months. But yeah, I would definitely make a diagnosis earlier than so in many patients, at least, it's all right. I'd say, to do that earlier. So I wasn't too concerned about that inclusion criterion. So we would, and actually, so I'm quite happy. There are some instances, for example, if you have a DVT, isn't it? And then, you don't know, is there still an issue with that? But I'd say very often we are comfortable after the most common pathologies, for example, a fractured dorsal-radius fractured, that you can do it earlier. I don't know what we said in Valencia. Actually, I'll have to look again. I know in the guidance, as I said, we said 1 month is really a bit early.
Okay, we have to look at. Well, I keep telling my residents, we're already treating it the way we would treat a CRPS, but we wait another 2 or 3 weeks just to make sure it's not in the phase where things get better anyway. And so we just do the full treatment, but we don't label it. We give ourselves a little bit more time for this. Well, that's a practical, so I'm not a scientific argument.
I have a question from Keith Smart. Hello, Keith. A question for Colleen. Do we know anything about the effects of providing condition-specific information to people living with CRPS on pain perception, disability, or healthcare use, for example?
Can you repeat that question, please?
Do we know anything about the effects of providing condition-specific information to people living with CRPS?
No, I haven't looked at that. What I do know anecdotally is that people that go to pain management programs, for instance, get a lot of benefit from them, but there's always little specific things about CRPS that don't relate to other pain conditions, and people do want specific CRPS information. So if you go to a general pain management program, for instance, maybe there could be a side part for CRPS, people with CRPS, but I haven't studied that in depth yet.
I want to quickly add something from broader psychology fields, which is that people who produce trauma responses for people who are involved in natural disasters have found that these sort of plug and play sort of trauma response resources are much more effective if you label them, this is a flood recovery system, this is a fire recovery system, but it's actually the exact same trauma recovery process. So there is literature out there that people respond, even if it's the same advice, people respond better when it's tailored to their situation and their condition, which is interesting. But of course, there are specific things about CRPS that are different to other chronic pain conditions. So that also makes sense. I have a question for Marc Henri, if I may, which is, you chose as your primary outcome measure disability, which I was intrigued by because, why not choose, for example, CRPS severity?
Because I'm a physical medicine doctor, so for me the disability is the most important. But of course, we'll also use the CRPS severity score, etc. But for me, the disability was the most important part. And we are used to say, okay, maybe you have some pain, for example, low back pain in clinic. I don't care that the pain is changing in 6 months, but I want that you can do more things in 6 months, for example. For us, it's a more important goal than just the pain or the CRPS severity score. Of course, we'll check it, and also the Budapest criteria and so on, but disability seems to be a more important objective and endpoint for us.
I wonder if
you
Colleen
assess
would
this
have
again?
something.
Sorry.
I just wonder if
Sorry.
Colleen would have something to say about that. Colleen, would you say that disability, in your experience and from your research, would you say that disability would be the most important primary outcome measure, or do you think that you would be considering something else?
Honestly, I think it's an individual thing. For some people, they are quite disabled, and that is the most important thing for them. For other people, it's the level of pain where they can walk or they've got a pretty much functional limb, but they're just in a lot of pain. I think it's just has to be seen as an individual thing. Sorry, that doesn't help with the research side of it.
I have a
Okay.
question I blurted in. So how do you assess the function? I think I missed this probably in your talk.
Yeah, I
Because
didn't
that's
say
not so
it.
easy.
For the upper limb, it's the quick dash, and for the lower limb, it's the lower extremity functional scale. The problem is that it's two different scale, one on 0 to 100 and one on 0 to 80. So we'll still need to check how to try to merge them. If it's not possible to assess them separately, but we'll probably have a lack of power.
Yeah. I think the dash is really a good thing to assess. I think that's a very good choice. That's what we are also using. So
I have a
but
very
I think there was a study where people were asked, and I think their major what they really wanted is to have a pain reduction. So that's why I'm interested. I thought it's interesting what Colleen said. I think we like better function, but patients want less pain. So
I know Caitlin has to shoot off in a moment, so I have a very quick question for her before she goes. Caitlin, did you look to see if the degree of disturbance symptoms correlated with pain intensity at all?
Yeah, I did. So I didn't have time to go over it today. But yeah, we looked at both just the body perception measures that we took on their own and whether they correlated, and we found that they did correlate with CRPS severity score, brief pain inventory interference scores, as well as the actual desired perceptions that people were also reporting. And then what we also did is we looked at whether the cluster groups that we identified was impacting those correlations. And again, we found that there were differences. So really interestingly, we found that for those desired clusters that I talked about, the group that had a really strong desire for a limb that did not represent a normal limb, which in itself was quite surprising anyway, we found that they were the ones that had the highest CRPS severity, as well as the highest brief pain inventory score. So yeah, we did look at, and again, with the perceptual disturbance clusters, we found that the group with the most severe ones with the multimodal agreement had the worst CRPS symptoms. So yeah, we did actually find correlations between important CRPS, other CRPS symptoms, but as well as those cluster analyses actually having an impact on those correlations.
That's super interesting, and I wondered whether you'd be prepared to speculate on a causal relationship between those variables. Do you think it's body perception that drives pain intensity, or vice versa, or do you have any thoughts?
I mean, the diplomatic response in me wants to say, can't be sure, it's a bit of both, but I think just from, yeah, sort of deep diving very much into the body perception side of it, I think my personal instinct would be that the body perception disturbances are at least playing a role in maintaining that pain intensity and the CRPS severity symptoms. Causal, not so sure at the initial stage, but I think maintenance for sure. And I think, again, 15-minute presentations, you never get to say everything you want to say, but I did actually do a qualitative study within this survey as well, where we explored a little bit more about patients' perceptions of their limb, how they make sense of their experience, and how they explained their reasoning for their desires. And within that qualitative analysis, we did actually see that, at least from patients' perspective, they were saying that the disturbed perception of their limb, it felt like that was the reason for their pain. That was the reason for their impaired motor functioning. And again, as part of this very large exploratory survey, we also did look at whether people thought that if they changed their limb in the desired way, it would improve their motor functioning and their sort of daily tasks. And they all had the perception that it would, in fact, improve it. So yeah, we did sort of get insights at least into what the patients felt that causal direction was like, and they at least did feel like their body perception was maintaining some of those other difficulties.
Thank you. And Heike?
Yeah, I have a quick question because I was very impressed by your VR approaches. I was wondering, what do they do with their hands once they, or what do you think is important? Are just looking at them, or
Yeah,
do you want them to do some movements?
That's partly what we are going to be exploring in my co-development with the patients. So when I look at other literature that used virtual reality with patients, it ranges from just looking at the hands all the way to doing specific movements. But I think obviously the important thing is that when you're working with people with CRPS, what we take for granted to be a really simple hand movement might be quite painful for them. So part of the co-development process is going to be about understanding the types of movements that will be useful for them, but also not push their pain to a point where it sort of is counterproductive in terms of it wanting to be a rehabilitation tool. At the moment, I'm using this VR tool with healthy individuals as part of a separate body perception investigation. And for that one, we do actually have very specific hand movements that they go through to just standardize that experience. But I imagine with the patients, I'm going to be much more flexible and just ask them to move the hands in a way that feels meaningful and useful to them. But yeah, that is one of the insights that we'll hopefully gain from co-developing it with the patients over the next few months.
Yeah, well, you could improve hand therapists or physiotherapists telling you which movements are actually critical every day in terms of the function. Probably you're doing this anyhow, but I was just thinking of this.
No, I hadn't actually thought of that. That's a really useful suggestion. Thank you.
A quick question from Colleen from GU. So she asked if she has consent to use the brochure, your brochure, and whether there would be the possibility to translate it to other languages.
Yes, absolutely. We would love people to use the brochure and share it widely, because then we can actually make a difference to people and help people with the condition. The only thing is I can't share the brochure, but if you go to the Purple Bucket website, you can download the brochure. They've got it. So I'll put that link into the chat. As far as translating it, absolutely. If we can use this throughout the world, that would be fantastic. But as I said earlier, I'm sure it can be improved. I'm sure the collective wisdom of everybody can help us improve it. And we do need more information so that when people click on that link, they see more than just an online brochure. We really need people to go to information.
I have a final question, and it will likely be a quick one just before we wrap up, and it's to Marc-Henri. I was just curious to know whether you looked at pain intensity as a predictor of outcome. I think that for most conditions, it tends to suck up most of the variance. So I wondered if it was similar in your analysis.
You mean the cluster analysis? Why we didn't include the pain?
Even a univariable analysis of pain intensity predicting outcome. I wondered if you looked at that.
Yes, we will include it for the analysis for the after 1 year. Okay, but for the cluster, we thought that it was more an outcome than something for the pathophysiology, but it's questionable. I totally agree about that. So yeah, we didn't include it for the cluster analysis, but we will, of course, for the mixed effect model for the prognostic factors.
Thank you. Thanks so much for clarifying. Okay, so we might just bring the discussion to an end. So firstly, I'd like to thank all of the speakers for their time and for sharing their fantastic research. I'd especially like to thank Greg from IASP for his support and enthusiasm in organising the event. Thanks so much, Greg. And finally, thanks to everyone who's joined us online, especially people that have joined either before or after work hours. And I just want to conclude by once again plugging our CRPS Special Interest Group. If you're interested in CRPS research, please consider signing up to membership. And as Greg mentioned, we'll also be holding a pre-IS World Congress satellite meeting in Bath on August the 3rd, which is a Saturday. It'll be an event that goes from midday until 6, and we'll have a nice dinner to follow, and it'd be great to see everyone there in person. So thanks once again, and with that, I'll hand it back over to you, Greg.
And thank you very much for the kind words, Michael. I assure you all I do is send a bunch of emails. It's all the work that you guys put in and your brilliant insight that makes this happen. But as you've rightly stated, we've come to the conclusion of the IASP Complex Regional Pain Syndrome Special Interest Group's Early Career Research Showcase. I want to thank once again Monica, Caitlin, Colleen, and Marc-Henri for presenting today, Heike, Ji-Yoon, and Andreas for joining us for our Q&A session, as well as Janet and Michael, who did a wonderful job of moderating the session. I'd also like to thank Jan Gerth-Mulen for helping to coordinate this webinar as well, although they couldn't join us. As a reminder, the recording of today's webinar will be available on IASP's Pain Education Resource Center, and we encourage all of our IASP members to explore the other offerings available there. We're going to be back here this coming Monday, May 13th at 3 p.m. Eastern US time for our next webinar, being produced in collaboration with IASP's Pain and Placebo Special Interest Group titled The Appetitive Side of Placebo Effects in Brain and Behavior. Thank you all so much for your participation today. Take care and all the best.